So Tim and I are stepping in, and I ask you for a little grace in bearing with us because we're trying to pretend to be Michelle, and Michelle's very hard to beat for those that know her. So, jumping off, I want to talk a little bit about the data that we have for opioid response in overdose deaths by race and ethnicity in New Jersey. These are looking at counts. I'm a data person, so I always have to kind of go back and explain the slide. So if you're looking, I can't see all the way to that end. If you're looking at the blue line, I wanted to make sure I called the right one. The blue line is what's been in the media a lot lately. Opioid deaths have flatlined. There's not an increase going on. However, if I go ahead and I look at the various race and ethnicity breakdowns, I am seeing a difference, and it's very disturbing. I'm a good epidemiologist, and I don't go on counts a lot. I like to go on rates and be able to say what's going on with the rates. When I look at the rates, what I'm seeing is that those among whites are declining. Those that identify as black are increasing. And there was a crossover in about 2018. So whites have been going down since 2018, but people who identify as black have continued to climb. Unfortunately, we're also seeing the climb continue among those that identify as Hispanic. So we're not at a point where we're ready to give an applause. We still have a lot of work to do. This is a very busy slide. I do apologize, but just to help everybody out, if you're looking on the left, you're looking at what's going on among people who identify as white. If you're looking at the right, you're looking at those that identify as black. And if we look at these comparisons and saying what's going on with overdose deaths across our state, very concerned when I look at the right, in Passaic County, that is the highest death rate, is in Passaic County among people who identify as black. We have a lot of work to still do. I think when we hear about our opioid epidemic, a lot of what we hear about is our young people, our youth. That's true among white. That is where we're seeing among the 25 to 45-year-olds. If you look on the right, our black African-American individuals that live in New Jersey are older. We're looking at 50-plus-year-olds. We don't see them. We don't acknowledge them. We are focusing on the youth, yet this is an epidemic that is crossing age groups, and we really need to have services that are covering the gamut as well. Another interesting part here is when we look at what drugs were used for the overdose, and we're seeing more stimulants among those that are black or African American. We don't see that same going on. Let's be honest here, opioids is really what's getting there, but there are stimulants that are in there as well. So it's something that we really have to be focused on and be aware of when we look at our approaches. Looking at some of our EMS data as well, and looking at naloxone administrations, there's a lot of data going on in the slide, but I just want to kind of walk through. If we're looking at the light blue line, I'm going to try to see, and I cannot see. Okay, 25 to 34-year-olds. What we're seeing is among the 25 to 34-year-olds, you're seeing a decline. If you look at the naloxone administrations, that's not where we're seeing the majority if you follow each year in the percentage. But now you go down and you look at our older individuals, 55 plus, you're seeing the increase. So it is something where we have to be aware that this is not just among young people. Nope, I was seeing this. All right, when I look at race and ethnicity in terms of our naloxone administrations, again, we're seeing a decline among those that identify as white overall, yet we're seeing an increase in the black individuals, as well as a slight increase among Hispanic. So again, there's a lot of work that needs to be done. Naloxone needs to be made way more available in our communities, especially our communities of color, and we have a lot of work to do. So, why do we think we're seeing this flattening of our line? What's going on here? What could potentially be driving this? And a lot of what is driving this, when we look at it, is so many factors. First of all, we have to remember that our overdose and addiction health conditions are really driven by social determinants of health. So when you add all of these factors together, we're seeing a division there. The second is when we look at opioid prescriptions. pain medications were largely prescribed to individuals who identify as white. They were not used by people of color. So with the crackdown on opioid prescriptions, that's where we're starting to see a difference. And you can see in the graph the decline of the opioid prescriptions that have been coming. So we have a lot to do, and the last one we want to say too that's going on is when you think about things like buprenorphine, the medication for medication for opioid use disorder, I will get all my acronyms down, that's not likely to be prescribed among our persons of color. So again, I start our talk off with, we still have a lot of work to go, and the data is showing us where we need to be. So I'm going to turn it over to Tim to talk about a little bit of the work we do, and I will be back.
Good afternoon. Again, my name is Tim Saplacki. Had the pleasure of working with the Department of Health for the past 20 years. I started my career actually as a paramedic, so emergency medical services is actually something very near and dear to my heart, and you hear me kind of refer to EMS and how EMS has gotten involved with the SUD epidemic and how it's changed over the years. If you had asked EMS 10 years ago or even 5 years ago, are you part of public health? And their answer is no, we're emergency services. They don't quite see the kind of the forest through the trees sometimes. If I was to ask, how many people in this room have never heard of xylazine? Anybody? Anybody not heard of it? Raise your hand, please. Don't be ashamed. Please raise your hand. I didn't know what it was 4 years ago, 5 years ago, so seriously, raise your hand. How many people? So xylazine, when we talk about medications and we talk about illicit drugs that are out on the street, they can mix them, right? It's polysubstance. And they've been mixing, it's nothing new, they've been mixing medications for many, many, many years. When I started my work, obviously in EMS and working with data and starting to see the kind of the evolution of the drug epidemic and the opiate epidemic, one of the things we saw was kind of a changing of polysubstance and other chemicals and things that are being introduced into the drug supply. And it's been going on for years, obviously, it's nothing new. Back 10 years ago, I remember working with state police and the drug monitoring initiative, and they would say, oh, well, they're mixing it with fentanyl, or it's remifentanil, it's a fentanyl analog. And I learned that there was more than just medical grade fentanyl. And I thought, what do you mean, fentanyl is fentanyl? They said, well, they change one molecule, and then obviously they stamp it not for human consumption, and they mix it with the drug supply. And of course, me being naive, being in EMS and not law enforcement, I said, how do they know how to do this? How does a drug dealer know how to do this? And he said, they're not. They're pharmacists. They're chemists. They know how to do it. They've adulterated it. And what that's allowed for is obviously for medication or for drugs to be created and a lot cheaper. If you have like a brick of heroin, heroin's probably $50,000, but a brick of fentanyl, chemical fentanyl, could be like about $5,000, and obviously it can be sliced a lot more and spread out and kind of expanded. One of the drugs that we've found in recent years is obviously xylazine, and the problem with xylazine is it's not made for human consumption. It's actually an animal tranquilizer. So out on the street or EMS, you'll see them, they'll call it horse trank or trank. And the idea behind that is the one difference between fentanyl and heroin is fentanyl is a little bit shorter acting. So what happens with the xylazine is actually kind of draws it out a little bit longer, gives it a greater high, kind of maintains it. It gives them that zombie kind of atmosphere. That's why they call it the zombie drug. They kind of just look like they're a bulking zombie. Heavily sedated, it can complicate the overdose. And the reason why is because it doesn't respond to naloxone. Naloxone is an opiate agonist, meaning it only works on opiates. So if I was to take Narcan right now and squirt up my nose, other than getting a little bit of an upset stomach, probably not going to think it's going to happen to me because I don't have opiates in my system. But when you mix it with xylazine, you mix it with other drugs, Narcan can work on the opiate, but it's not necessarily going to work on the other medications like xylazine. Still indicated for giving it, obviously, but it's one thing that we have to train our providers that when you have these polysubstance overdoses, we have to make sure that we're ready to work on their airway and manage their airway as well. One of the other big issues with xylazine is it creates really bad abscesses in the arms and so forth, almost like crocodile type skin, and it can cause abscesses, it could cause them to get sepsis, and they can actually die of sepsis as well. So it creates a whole nother health emergency. We started seeing xylazine, and speaking with some of the ER physicians, xylazine's been around for several years. It's kind of been low, very small in the drug supply. However, in the past few years, especially with the evolution of fentanyl, and now most overdoses in the state are all fentanyl, about 9 out of 10 overdoses. There's very, very little heroin. It's mostly all fentanyl or some type of fentanyl analog. So as you start to see this, you're starting to see other drugs being introduced into it, and xylazine being one of them. It's almost always accompanied with an opiate because, again, it precipitates that fentanyl. And again, about 90% of the drug supply has fentanyl or almost pure fentanyl. Very rarely will you see xylazine in pure form. It does happen, but it's not as common as say, fentanyl in pure doses. About 13% of our deaths, we started seeing a marked increase in deaths that involve the xylazine as well. So how do we deal with this? Well, from EMS standpoint of view, like I said, a lot of folks don't realize that when a patient overdoses, they're reversed with naloxone, EMS will manage their airway. When the patient wakes up, the patient has a choice. The patient can't be forced to go to the hospital. So therefore, the patient, if they're alert, they know where they are, they know what happened, they can actually refuse transport to the hospital. Nationally, it happens about 21–22% of the time, but I can tell you firsthand that that's grossly underreported. And the reason why is that's based upon the fact of somebody that received naloxone from EMS or from law enforcement, not prior to them getting there, and then they were reversed by EMS and then they refused transport. If they received it prior to EMS getting there, that's not counted. If the patient is under the influence but not necessarily overdosed, that's not included in it either. So we start looking to see where EMS is starting to take a shift into more of that public health and community response realm, and that's where it becomes more and more important. When we start thinking about 30–40% of those patients realistically are not actually making it to the ED, pretty much EMS and law enforcement, they're the only first responders, they're the only medical professional that patient's going to see. And that was one of the cornerstones of how we got started on a lot of the projects that we did. New Jersey was actually one of the first states in the country, it was the first state in the country actually to allow their paramedics to administer buprenorphine. Buprenorphine is obviously a partial agonist. Basically, the way it works is with buprenorphine, they'll mix it with naloxone, it's called Suboxone, and it allows the person it suppresses the cravings and it also suppresses those withdrawal symptoms. And that's one of the hardest things to understand is that when you reverse somebody with naloxone, you're kind of putting them into withdrawal. You are putting them into withdrawal. So trying to solve the withdrawal symptoms as well as to serve those or to curb those cravings. And that's where buprenorphine or Suboxone came into play. Methanone's been around for a lot longer. Buprenorphine's only been around since early 2000s. Methadone has actually been around since the 60s. It's a full agonist. It can help to stop the cravings and also the withdrawal symptoms. With methadone, it's got a higher tendency to be abused, and it's a little bit tighter control, a lot tighter control than Bup is. And then you have naltrexone. Naltrexone doesn't necessarily work on the withdrawal symptoms, but it will help to reduce the cravings, and it usually goes for a longer period of time, usually a 1-month injection and so forth. So the evidence, there's been a lot of studies done on medication-assisted treatment and the importance of MOUD. When we talk about methadone, you can see in the blue lines, those are folks that had opiates within their system versus patients that did not, that were given a control and had opiates within their system. With buprenorphine, we see a greater chance of them curving off of the opiates. Blue is the ones that receive buprenorphine versus a placebo. The red ones are the placebo. So we know it works. We know it has helped a lot. In other states, we've seen high, as much as 60% can help somebody. It can reduce their chances of dying up to 60%. So it's incredibly important. It's a cornerstone for help. And I always use the example, in EMS is, well, we're not counselors, we're not, addiction specialists, so why are we getting involved in this? Well, if you look at it the same way as a diabetic, right? If you have a chronic disease such as diabetes and you have a chronic disease such as SUD, when you have an EMS response, EMS is going to respond, the patient's unconscious. Right? They get there, they assess the patient, manage the airway, they administer medication. For the diabetic, they're going to give them something called dextrose, which is sugar. On an overdose, they're going to give something like naloxone or Narcan. Right? Patient wakes up under both circumstances, their sugar is corrected, Narcan reverses the opiate, they both wake up. With the diabetic patient, EMS will offer them a resource. Do you want to go to the hospital? The patient says, no, I'm okay, I don't need to go to the hospital. So what do? They offer them more resources. They give them a sandwich, they tell them they need to eat. You need to have some complex carbs, otherwise your sugar's going to drop. I also recommend you follow up with your doctor. Do you have a doctor? Sure, let's make sure you make an appointment with your doctor so they can adjust your insulin. With the overdose patient, what typically happens? You want to go to the hospital? No? Sign here. And that was it. There's no resources, there's no anything. So that's why we started realizing the importance that EMS can actually play a big difference and actually help to introduce that idea of recovery and understanding where they are, and through several programs that we'll talk about throughout the day. We've tried to integrate that in to kind of change that stigma of SUD, as well as understand the importance of meeting those patients and the idea of having that time where you can make a difference with that patient and offers them some resources. One of the biggest pushbacks when we did that was they said, Tim, we don't know where to send them. But I don't know where to send them. Where do we go? So when we started off a program called 5 Minutes to Help, so we'll talk about it a little bit, and Colleen and her group actually were one of the ones in getting that up and running and instrumental. It's a program that we're really proud of, which helps change that stigma. It helps with those resources. So we need to take it to the next level, because with EMS, they don't know where to send them, and they don't have those resources readily available. So we start to think of those access points. One of the things we do is we start thinking, utilizing those EMS, like I said, with paramedics and buprenorphine, and putting it on the truck. So if the person is ready to get some help, they can say, hey, listen, we can make an appointment. We can get you into it tomorrow. We can make sure that you don't get sick right now. We can give you something to make sure you don't get sick. So we've started to do that already. We've worked with the emergency department, so they have those resources available. One of the things several years ago, when they would have somebody that overdosed, and law enforcement or somebody say, well, they have to go to the hospital, and they would kind of coerce them or force them to go to the hospital, and then the ER would put them in the waiting room. They put them in a waiting room, what happens? They're going to walk out the door. Why? Because they're going to get sick, right? So they want to make sure that they have those resources available within the hospital. Harm reduction centers, understanding what they are, where they are, and how they can be utilized is critical. And then, of course, a telemedicine piece, which has been absolutely huge. Not everywhere has a clinic right down the road, so we need to be able to address those patients that are in rural areas and don't necessarily have those resources readily available. So we want to reduce some of the barriers as well, and that includes travel vouchers, it includes medication vouchers to make sure that they have the ability to get help and not have financial resources as a limit to that. One of the projects that we're extremely proud of rolling out, and we hope to roll it out over the next 4 years, is a program called MATTERS, where it's medication for addiction treatment and electronic referrals. So we just call it MATTERS because that's way too long to talk. So we call it MATTERS. It actually started up in New York as New York MATTERS out of University of Buffalo. Dr. Josh Lynch was one of the head physicians that started it, and it's proven to be extremely successful. So what it does is it's a platform. It answers that question, what do I do with them? How do I offer them resources? What resources are available? Imagine being out and having somebody that overdoses and says, hey, there's a clinic right down the road. We can get you an appointment anytime between 9 and noon tomorrow. All you have to do is show up. And we can literally do that through an application right on the spot. We can offer them resources, static resources for harm reduction. We can offer them where syringe access is available. We can offer them telemedicine. We can get them Narcan. We can get them vouchers for that travel. Hey, I can't make it to that appointment. How do I get there? Here's a voucher to get them there. And it all ties in within that app. So when you look at different organizations, community organizations, our EMS agencies, our law enforcement, again, it ties in that common database and that common app where they can actually get them those resources. And if there aren't those resources, there's that telemedicine piece. So there's always somebody there to help 24/7, 365. And it ties them in with those treatment organizations. So this is kind of a look to see up in New York. This is the way that they have all of their clinics that they have partnered with. You can actually click on it. It'll tell you exactly what that clinic does have and what it doesn't have. All of the resources, and then of course it allows you to enter in the information and then pass that and make that patient an appointment right on the spot. So I'm going to turn it back over to
Thank you. Thanks, Tim. So now we're back into the stuff I know a little bit better, I promise. So harm reduction is been thrown around a little bit today. I'm hoping that many of you are familiar with harm reduction. I think a lot of us think about it as clean needles, and that's where we're stopping. But it's so much more. and what we have to offer. So harm reduction is a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. It's also a movement for social justice built on a belief in and respect for the rights of people who use drugs. We're not here to say you can't use drugs. We are meeting people where they are and helping them to stay as safe as they possibly can be. I think it's very important, especially with our opening statements and proclamations, to really recognize that this was coming out of a civil disobedience. This is done by people who have lived experience. They are the best at it. They're there to fight for the individual who doesn't seem to have a voice, and they are their voice. So this is not the government coming in and saying this is what you're allowed to have. I say that as I work for the government. This is people who really want to make that difference. And I think sometimes we get into a little bit of what's the difference between treatment and harm reduction. Treatment is when that person is ready to make that change and they want it. If they're not wanting to be there, it's not going to be helpful. For harm reduction, we are recognizing, hey, we know what you're doing. What do you need? Do you need a place to stay? Do you need a place to get some food? Do you need some clean works? That's what we're here for, and that's what we'll do. So it's very important to recognize that harm reduction is not going to first try to say, well, you can't be using drugs, they're bad for you. That's not what we're here for. We recognize that this is where the person is at, this is where we're going to meet the person, and we're going to help them with their immediate need today. And if we can help in a couple of months where they come back and say, hey, you know what, I'm ready to talk, what can we do? Then we're going to make those connections. So we work very close together. So some of the principles of harm reduction, recognizing that there's inequities and intersection with harm. It's not always just about the substance itself, but you look at how are they getting access to those substances. I see, especially in my day job in the STD HIV world, I see a lot of women who are getting their drugs by selling their bodies. And these are realities that we face, and we need to help them have how to be as safe as they can be. Our services are non-coercive, non-judgmental. In many ways, we're looking at the efficacy of harm reduction in ways that people are treated, not the services. We want you to be recognizing you are a human being and you deserve better. Harm reduction is always working toward the empowerment of people who use drugs. Just because you're using drugs doesn't mean that you don't have a voice. I can't say it enough how important it is that they are still human beings and they deserve all of the help we can get them. Harm reduction is always ideally led by people who have lived experience or who are using drugs themselves. They understand what needs that person has the best. I can't make that judgment, but I'm here to help any way I can. And it's always important to remember that abstinence is not necessarily the goal for harm reduction. It's really about helping the individual's self-determination to say where do they want to be, and we're going to help you get there. So some of the strategies is probably the stuff we're most familiar with when we're looking at having access to sterile syringes, other safe equipment, having naloxone available, having fentanyl test strips available, having xylazine test strips available. There's just so many ways that we can help and what we can have there. And many of the services delivered at a harm reduction, but many of them can go other places. It doesn't need to be in a harm reduction center anymore. And that really comes when you start looking at, let's talk about our everyday harm reduction. Every one of us does harm reduction every day. You probably don't recognize it, but if you put a seatbelt on your car to park in the yellow lot and walk over here in the rain, you did harm reduction today. If you woke up and brushed your teeth, you're preventing tooth decay, you've done harm reduction. Bike helmets, motorcycle helmets, condoms. I know nobody uses them, but I ask you please all use them because that's, again, my day job. Everybody who gets vaccines, when we look at the fact that if you look just 100 years back, 1 in 3 babies died in childhood. And that isn't a thing anymore. If you ask your grandparents today, how many children did you lose? They didn't. because they had vaccines. Whereas when I think about my family tree, because I'm a genealogist by fun, there's so many babies that did not make it because of diphtheria, measles, rubella, all of these things that were common just 100 years ago. And then also, probably another one, I'm on a college campus, designated drivers. I know you guys get to walk, but how important is designated drivers as a harm reduction approach? Because by having that individual who makes sure, or in the rise of Uber, guys, Uber is a harm reduction approach, because that way you're not at risk. You will remove the risk, but you're still going to do the behavior, and that's okay. So we are very lucky to be in the state of New Jersey. I have heard some of the other horror stories that go on. For those that might not be aware, I think now about 10 years ago, there was a HIV outbreak in Scott County, Indiana. Now, nobody probably knows where Scott County, Indiana is, but go to the rural south of Indiana, that's where it happened. I believe they ended up with about 250 new HIV diagnoses from needle exchange alone. And it was a battle to get a harm reduction center opened to ensure that everybody had access to Clean Works. They opened up a harm reduction center, and all of a sudden, no new HIV cases. Now, when you look really in depth at Scott County, Indiana, it was multi-generational. Parents were going in with their parents and their children and all being diagnosed with HIV because the families were all sharing their equipment. It is so important and so lucky that we live in New Jersey. So in January 18th of 2022, Governor Murphy signed into legislation expanding our harm reduction services statewide. Before 2022, in order to open up a harm reduction center in New Jersey, we required a municipal ordinance. And I love my local health very much. They were very supportive. But when we had to go before city council or municipality freeholders in order to open up a harm reduction center, that's a little bit too edgy here. We're not sure that this is what we want to do. So this law removed the municipal ordinance. Again, those from New Jersey, we live and die by municipalities, and that is where the power is at. And we were very, very surprised that we gained the support of our legislators, because they recognized that if you thought you couldn't get elected again because you did this and brought it into my backyard, you're not going to do it. But there is a need, and people want to do this work. So, New Jersey Department of Health, we have the responsibility to approve registered harm reductions. We are required to inspect, make sure they're doing things the way they're supposed to be doing things and still following the laws. We have the regulatory oversight of syringe access services. Not be prosecuted. You can't get arrested for carrying syringes. You can't get arrested because you have a smoke pipe. All of this stuff is, as long as it's coming out of a harm reduction center, it's not considered paraphernalia. So we have very proud to be in the state of New Jersey. So in terms of the two categories that were decriminalized, better read my Michelle notes because she's going to tell me I didn't read them right. So the first up was the drug checking equipment. That has been removed. So any testing strips, including xylazine, and including whatever comes on the market next, we're ready. New Jersey won't have to wait to change the law to add it in or else. No. If you are checking the strength and what's in your drugs, you're able to do that. The other big change that came from here was syringes. So the law in 2022 only removed possession. It really left a murky area for distribution. So if I'm in an emergency department, I have syringes all over the place. Am I in trouble if I give them out? The changes in 2022 left a lot of gray area. And so in 2024, we cleaned up the gray area. And we took that out to say if you are going to possess, distribute, or possess with intent to use or distribute, that is allowable. And so that really is a game changer as well, because when we look at our emergency rooms, where we know a lot of people go, they can now be giving out syringes as well, and they don't have to do anything to get there. So lots of exciting changes going on, and hopefully we get it all rolled out and everybody educated accordingly as well. So what does this mean for our harm reduction centers? You know, in some ways the changes align with the criminal law and public health, and we're just being able to broaden what we're doing. It's not only just syringes and needles now, it's safer smoking supplies, safer sniffing supplies. We're looking at xylazine test strips and any other form of test strips that come out onto the market. We're really ready to go, and that is a huge game changer for New Jersey. I think it's also really important to say, if we become a Scott County, Indiana, and have an outbreak somewhere that we can tie where a harm reduction center is needed, we can have that up and running in no time, because all it takes is a form that the DOH approves and then work to get started. So really critical to be where we're at. But wait, there's more. So we've got what it means for harm reduction centers, but what does it mean for our healthcare providers? And I kind of gave this away already, because there's nothing stopping our emergency departments or medical providers from giving out syringes. They have now, if you're a licensed healthcare facility, an FQHC, anyone can distribute harm reduction supplies, because distribution is no longer a criminal act. We've also been trying to integrate our harm reduction into our healthcare settings, because as we talked with xylazine, how important it is that they're accessing medical care. If you're on the street using drugs and you have an open wound, sepsis is right around the corner. I need you to make sure you're getting clean wound care. And how can we integrate all of that together? So DOH is not requiring, this is Department of Health for all of you who love acronyms, the Department of Health is not requiring hospitals and healthcare facilities to get authorization as a harm reduction center. They can start doing it tomorrow from what we've read and had our lawyers approve through the law. For our substance use disorder treatment centers, we do encourage them to register and become a harm reduction center. It's not hard, I promise. It's very simple. And this would, help to make sure there are no penalties. Just have that extra coverage to make sure everything is okay. And we do recognize the important need to work together, because all of our harm reduction centers need to have friends at the substance use disorder treatment centers, because that's where we'll be able to refer and make sure people know where to go. We recognize that many of our individuals who fall out of recovery, they should know where their harm reduction center is. If you're ready to stop using drugs, you should know where your treatment center is. It's a collaboration, and there's no more working in our silos. We gotta work together. So I do want to take a quick moment to talk about safer smoking and harm reduction, because it is important to understand that this is also something, because we spend a lot of time on injection drug use. So they're looking at our Black communities. They're more likely to smoke drugs than to inject. And so if we don't have safer smoking supplies available, we're doing a disservice to that community. We are seeing more individuals who smoke drugs, and this recent MMWR, doubt you can read that, but if you look at where they're showing from January to June 2022 to January to June 2020 to July to December 2022, they're showing a 73% increase in people who overdose from smoking. And when you look at the number of deaths, it's going from 2,794 to 5,843. It's a 109% increase. We can't just focus on needles, we've got to look at the whole gamut. My last slide is just to talk about our overdose hotspot initiatives. So really looking at our data, where is our data telling us we need to go? Where are communities that we need to have a harm reduction center? We need to have education. We need to put naloxone packs in trees, because we know this is where people need to have access. So looking at some non-traditional approaches on how to reach the communities that are most in need. And with that, I will say thank you and open up for any questions or discussion.
Well, that was awesome. Thank you so much, Greta and Tim.